Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Dr. Raghda. First of all, I'm very honored to be with you all here. I'd like to thank you for your attendance. And without further delay, I'm going to be starting off with my talk. I was asked to give a talk about the skin manifestations of systemic disease, and it's quite difficult to summarize all this in 20 minutes. So I'll try my best to actually highlight disorders of interest. So as we all know that skin is the largest organ. It's a mirror or a reflection of what's going inside our body. At times, systemic diseases, they may have an occult or diverse clinical presentation, and that often poses a diagnostic challenge. Yes, dermatological disease, it may be the initial sign of an internal disease. In order to make it easier to understand, I've decided to actually divide the different disorders into different categories. So the first category, we're going to be starting off with the case. So this is actually a patient that I've seen when I was a resident. I was called to the ER to see this 46-year-old female. She was admitted with a 2 weeks history of this rash, as you can see, with a history of general fatigue, joint pain, and worsening rash. So what's the first thing that needs to come on your mind when seeing such a presentation? So this was a case actually of systemic lupus erythematosus. So the first category is going to be cutaneous rheumatology. As you can see, there is a wide range of different diseases. When we're looking at patients in rheumatology, and when we're trying to actually reach a diagnosis, we need to couple the history along with the complete cutaneous examination, look at the skin, look at the hair, look at the nails. Of course, we need to look also at the lab evaluation, especially that those patients have a high specific autoantibody panel, which we need to be aware about. A good number actually of rheumatological disorders do have a clinical criteria which we need to fulfill in order to make the diagnosis. And of course, if we want to further confirm the diagnosis, we can proceed and take a biopsy. And again, we need to clinically correlate the biopsy with the clinical findings. So starting off with lupus, as we're all aware that lupus is a multisystemic disorder that prominently affects the skin. There are different variants, and those variants could be subdivided depending upon the location and also depending upon the depth of the inflammatory infiltrate. So we have the acute lupus, we have the subacute lupus, and even the chronic. How do they present? With regards to the acute lupus, patient will have the butterfly rash along with the generalized rash all over the body. If it's a subacute lupus, the different presentations may include annular type of presentation or even psoriasiform type of presentation. But usually it's present in the photosensitive areas, especially the V-chest area and even the back. How about discoid lupus? We can see those vitelliginous-like patches along with perifollicular plugging. But again, we have to look at the complete picture of the patient. The next category is dermatomyositis, which is a disease of presumed autoimmune pathogenesis. Yes, dermatomyositis may present with a symmetrical proximal extensor inflammatory myopathy and clinical or characteristic cutaneous eruption. But keep in mind, sometimes dermatomyositis can be amyopathic. So of course, for us to be aware about the clinical characteristic findings will help us to confirm the diagnosis. So what are the findings with dermatomyositis? Starting off with the heliotrope sign. What does that mean? Patients are having pinkish erythematous patches in the periorbital area, and this could be also associated with eyelid edema. Patients could also have Gottram papules. What does that mean? Those are pinkish erythematous papules, which have a lichenoid type of presentation and mainly presenting on the knuckles. If the Gottram papules involve the elbows and the knees, at that stage, we call it the Gottram sign. So there's a difference between the Gottram papules and the Gottram sign. And of course, when we fully examine the patient and we look at the digits, you can find the ragged cuticles. And using a dermatoscope, we can also see that the patients are having dilated blood capillaries. So this will further confirm our diagnosis. A very interesting finding is the poikiloderma. So it means that patient is having erythema along with atrophy. And again, this is in a photodistributed area. But the poikiloderma is not only necessarily seen with dermatomyositis, it could also be seen with lupus. It could also be seen with cutaneous T-cell lymphoma. Vasculitis, which is the inflammation of the blood vessel, another also entity that we need to be aware about. Cutaneous vasculitis either could be a skin-limited disease, sometimes it could be a primary cutaneous vasculitis with secondary systemic involvement, or a cutaneous manifestation of a systemic vasculitis. And we usually are called a lot for the inpatient to see such a consultation. Now, with regards to vasculitis, it's divided according to the caliber of the affected vessel, starting off with the small vessel vasculitis, whether it's a leukocytoclastic vasculitis, which we commonly see. And of course, we need to rule out Hünigschulm purpura. So as you can see, this is a picture of a patient who I've seen having those purpuric patches, but as you can see closer, patient is having blisters along with that. So whenever we actually confirm that the patient is having Hünigschulm purpura, especially if it's an adult, we always need to rule out any secondary malignancy. Other types of vasculitis include the small and medium-sized vasculitis, such as cryoglobulinemia and the ANCA-associated. And as you can see, I actually put this picture of this cryoglobulinemia patient. But if you can look at the pictures, patient is just having the purpuric patches. You won't be able to say this is cryoglobulinemia by itself. Of course, again, you need to look at the full profile of the patient. With regards to the medium-sized vasculitis, we have the polyarteritis nodosa, and those patients may have the livido-racemosa and ulcers and retroform purpura. And for the sake of time, I'm not going to go through the large type of vasculitis. Behçet disease is another multi-system polysymptomatic disease with unpredictable exacerbations and remissions. It has different manifestations, whether it's ocular, joint, GI, or neurological, and even vascular. We do have this criteria, which we actually can go through. In order to confirm that the patient is having Behçet disease, patient needs to have a history of recurrent oral ulceration, at least 3 episodes in the last 1 year. This is one of the major criteria that the patient needs to fulfill, plus any 2 of the minor criteria. What is the minor criteria? Recurrent genital ulceration and eye lesions, whether it's the anterior or posterior uveitis. With Behçet, posterior uveitis is the most common ocular type of manifestation. With regards to cutaneous lesions, patients may have erythema nodosum-like lesions. They can have papulopustules or pseudofolliculitis. So even if we take a biopsy, we won't confirm it's Behçet. Again, we need to fulfill the criteria and look at the complete profile of the patient. And pathology test. What's that? That's exaggerated skin test, where exaggerated skin actually results, what can result, say, for example, from trauma, even from the needle stick injury. So this is also part of the criteria. How about rheumatoid arthritis? With regards to rheumatoid arthritis, we're all aware about the different manifestations, the swan neck deformity, the bottom-ear deformity. And along with that, we can see in the below picture where patients may have something which we call a bywater type of lesion, which is pigmented or purpuric patches on the distal extremities, and that's due to a small vessel vasculitis. Patients also may have something which we call rheumatoid neutrophilic dermatitis. And something that we need to be aware about, it's not only rheumatoid arthritis complications, it's the complications of the medications that we actually give. So patients with the rheumatoid arthritis, if they're taking NSAIDs, they are at high risk of developing something which we call pseudoporphyria, and that's due to medications. And even with methotrexate, which we commonly actually prescribe. With methotrexate, there is the risk of actually patient developing something which we call accelerated nodulosis. It might be uncommon, however, we need to be aware about that, and we actually did report that in 2016. Second category, we have a 47-year-old female. She was treated as a case of skin candida with no improvement. What are your guesses for this? Okay, so something which I have not mentioned, of course, us as internists, we always need to take a complete history for this patient. So with regards to this patient, he has a history of gastric carcinoma. So yes, this turned out to be cutaneous metastasis. So this is the second category, which is cutaneous hematology and oncology. I'm not going to go through the criteria for the sake of time. However, you need to be aware about Kurth postulates, which is a criteria used to associate a dermatosis and malignancy. What does that mean? That sometimes patient may have a dermatosis and then the patient will be diagnosed with the malignancy, or even vice versa. Or some types of dermatosis, once the malignancy is treated, it goes away. However, once the malignancy recurs, the dermatosis recurs back again. So briefly, we have the paraneoplastic dermatosis, starting with basic syndrome, which is an acral type of psoriasiform plaques, mainly on the nose it can present, and even on the helices. And sometimes this is actually associated with aerodigestive tract malignancy. Carcinoid syndrome, where a patient may present with flushing, whether it's in the head and the neck region, and this is also associated with mid-gut tumors. How about erythema gyratum repens? This is a type of figure-8 erythema where patients will have those concentric lesions, as you can see, and they're migratory. They move from one place to the other, and they have this wood grain type of appearance, and this is also associated with variable sites and types of malignancy. Glucogonoma syndrome as well, and signs of laseratory. We see lots of patients having seborrheic keratosis, and it's a very benign entity. However, if a patient presents with a sudden onset of seborrheic keratosis, and it's itchy, and patient is having a history of weight loss and also other features, we need to think about laseratory, and this may signify that this patient may have an underlying malignancy. Acanthosis nigricans, another common entity that we see. However, if it's a rapid onset of hyperpigmented velvety changes, it's at that stage we need to think about an underlying malignancy. So now the question is, so when we're seeing a patient with acanthosis nigricans, how do we approach such a patient? So this table actually will help us evaluate those patients. So if it's of a sudden onset with other symptoms or weight loss, of course, think about underlying malignancy. If a patient is overweight or obese, and this is what we commonly see, so of course, this is related to diabetes or insulin-resistant states. If a patient is having striae, hypertension, buffalo hump, think about Cushing's syndrome. And if it's a female having a history of acne, hirsutism, irregular menses, definitely this is related to PCOS. And yes, acanthosis nigricans could also be drug-induced. Medications that have been implicated include corticosteroids, oral contraceptives, and even human growth hormones. More of the paraneoplastic dermatosis, which is the acquired angioedema due to C1 esterase inhibitor. Patients will have angioedema without urticaria, and this is usually associated with the B-cell type of lymphoma. Amyloidosis, we see amyloidosis common in our clinic, but it's just a cutaneous amyloidosis. It's benign. However, when we see patients having particular purpura in the periorbital area, we need to think about monoclonal gammopathy. Dermatitis herpetiformis, again, patients will have pruritic erosions and blisters on the extensor surfaces, and this also can be related to a T-cell type of lymphoma. Mycosis fungoides, we commonly see it. This patient presented to my clinic as being treated as a case of psoriasis, and then she came up and telling me that I was started on biologic and I'm not improving. Definitely question the diagnosis. And looking at the pictures and the clinical findings, this was not definitely psoriasis. This was mycosis fungoides, and this patient turned out to be having follicular type of mycosis fungoides, and in those patients always rule out Sézary syndrome. Schnitzler syndrome, again, we're always called within the ED to see patients with urticaria. However, if this is associated with other features of having fever, bone pain, arthralgia, think about that, because this could be associated with an IgM paraproteinemia. One more thing that we need to note, the cutaneous reactions from chemotherapeutic drugs. As we can see here, we have the hand-foot syndrome. We're usually called from hematology with regards to that. It could be related to 5-fluorouracil. That could be actually divided into different grades. The erythema can be painless. It can progress to become painful, and sometimes it could be related to erosions. And as you can see, this is a characteristic finding, which is called flagellate erythema, and this is associated with bleomycin. Next category, this is a 23-year-old female who was recently diagnosed with rheumatic syndrome, and she was started on oral steroids. Yes, this is striae extensae. And the next category, which is the cutaneous endocrinology and metabolic disease. So just briefly, we already discussed acanthosis nigricans. However, patients with diabetes may also develop something which we call diabetic bulla, which is a tense non-inflammatory bulla, and we don't know what is the exact cause. The diabetic chiroarthropathy, here patients have thickened skin with immobility, and you can see they're not able to approximate the palmar surfaces of the hand, and this is called the prayer sign. And in the picture B, this is once the patient was treated, they were able to do the prayer sign. The diabetic dermopathy, patients actually present with brownish atrophic patches, and they're usually precipitated by trauma. Eruptive xanthomas. This usually happens in patients with poorly controlled diabetes mellitus, and they usually have a history of elevated cholesterol levels. And of course, if the diabetes is controlled, the eruptive xanthomas will disappear. Necrobiosis lipoidica, patients are having patches, which are yellow atrophic patches and plaques, and usually those are painful. And lastly, we have the scleroderma, not scleroderma, scleroderma. So this is different. Patients are having erythematous indurated patches. Usually it's on the back and on the nape, and we don't know what's the cause for that. You're all aware about the different manifestations of thyroid disorder, but with hyperthyroidism, we expect to see those indurations on the lower shin, and that's due to mucin deposition. And with the hypothyroidism, we expect to see the acquired ichthyosis. I'm not going to go through the Cushing syndrome because you're all aware about that. And we can see this striae, and there's a high risk of infection. And also with Addison disease, patients are having hyperpigmentation in different areas of the body, including the hair, the nails, and even the palmar creases. Last category, before the last category. This is a 32-year-old female, actually, we're called, and she has a known case of inflammatory bowel disease, consulted for fever and this rash. This is actually a case of sweet syndrome. So with regards to cutaneous gastroenterology with inflammatory bowel disease, we have the Crohn's and ulcerative colitis. What are the findings we expect to see? Erythema nodosum, which are patches and plaques, which are usually tender on the lower extremities. But yes, erythema nodosum can even present in the upper extremities. Vasculitis is also common with those patients. Pyoderma gangrenosum, as you can see. And the below picture, what is pyoderma gangrenosum? This is a neutrophilic type of dermatosis. Initially, patients will just have a pustule on erythematous base, and then it's going to progress to become to this necrotic undermined border. And this is associated with different diseases, whether it's inflammatory bowel disease, monoclonal gammopathies, and even other hematological disorder. For the sake of time, I'm not going to go through the different clinical variants, but yes, we do have a criteria to diagnose pyoderma gangrenosum. Sweet syndrome, as like the case that we have actually discussed, patient will present with erythematous plaques and they're occasionally bullous. And it's not only the presentation of the skin, patients will have other constitutional signs, including fever and malaise. And of course, this is also associated with inflammatory bowel disease, malignancy, drugs, pregnancy. So we need to keep that in mind. And yes, there is a criteria for the diagnosis of sweet syndrome. Peristomal skin disorders, we commonly see that at the area of the stoma, patient would have an allergic contact dermatitis because of the adhesive ring. And pyoderma gangrenosum can also occur at sites of the stoma. Again, for the sake of time, I'm not going to go through all of this. However, we've already discussed about Crohn's disease with scurvy. Patients, we expect them to have a corkscrew hair. They can also have perifollicular purpura at the area and even gum bleeding. Kaposi sarcoma, it can also occur where patients are having violaceous macules and papules. And it not only affects the GI, it can also affect the lungs. How about hepatitis B and C? Those patients, they have high risk of having urticarial vasculitis as opposed to urticaria. Usually this is painful and tender. It heals with hyperpigmentation, where urticaria does not actually leave any pigmentation. It's usually itchy, not tender. Lichen planus, and you can see the Wickham striae in the oral as an oral disease. And briefly, the last category. So we have the renal disease, but something I would like to highlight. We've already discussed systemic lupus, scleroderma, briefly with the crest and the Raynaud's phenomenon. Of course, they do also have renal involvement. Hünnig-Schönum purpura, we've already discussed as well in the part of vasculitis. And sarcoidosis, of course, those patients may have plaques, nodules. Keep in mind the different types of syndromes associated with sarcoidosis, the Hereford syndrome and the Lofgren syndrome as well. Renal disease, we commonly see it. Patients will have commonly cirrhosis, and especially those patients who are having uremia. And we can see, though, this is the picture actually of the patient having a Acquired perforating dermatosis, we commonly see it. And of course, to diagnose it, patient, we need to take a skin biopsy. Calciphylaxis, it's usually tender. It's actually life-threatening. Most of those patients, it's because of vascular calcification. And this may lead actually to death, and even death due to sepsis or even infection. How about those patients who are having renal disease on long-term immunosuppression? They're at high risk of having squamous cell carcinoma and even Kaposi sarcoma. Those patients need to be screened at least on a yearly basis. Pulmonary disease, again, we already discussed sarcoidosis, dermatomyositis, we've already discussed as well. Kaposi sarcoma, as I mentioned, those patients may have involvement not only of the GI and the pulmonary. Tuberculosis, patients may have lupus vulgaris, and we have the scleroderma. What does it mean? Patients having caseous lymph nodes which are infected. It may rupture to the skin, and you can see that. And varicella, also patients with varicella as well. I believe I've run out of time.
Okay. Need more time? 2 minutes?
Just 2 minutes, less than 2 minutes. And since they've been talking about varicella, yes, we as dermatologists, we see commonly varicella. Those patients will have lesions of different stages. And of course, if patients having a pulmonary involvement, this correlates with the severity of the condition. And the last part is the cardiocutaneous. Again, for the sake of time, I'm not going to talk about it, but this is a patient who I've seen with neonatal lupus. So we need to be aware that with neonatal lupus, those patients are at risk of having congenital heart block and psoriasis. We see this on a daily basis. So those patients with psoriasis, they're also at risk of having increased risk of cardiovascular risk, such as metabolic disorder. This is a quick summary of the different types of categories that I've discussed. As I mentioned, it's difficult actually to summarize all of this in a very short time period. So in summary, systemic disease does influence or pose a diagnostic challenge. It's very important to recognize such manifestations to allow for earlier detection and treatment while avoiding potentially life-threatening complications of such illness. With that, I'd like to end my presentation. Thank you very much for listening.